head compression can lead to passage of meconium. I think it stands to reason the deeper the meconium, the greater the risk of disease. Now you might ask yourself, why are we doing away with the intubation for meconium? Like, what's the rationale for that? Because the theory behind intubating had been that what's happened is you've had gasping respirations that suck the meconium down to the airway, but you then go on to that secondary apnea that we learn about in NRP, right? And so if they're in secondary apnea, the baby's not breathing at all, so that meconium's just sitting here. So if you put the tube in, you can suck it out, right, and prevent them from getting the meconium aspiration syndrome. The problem with that is that what was recognized were many people were so focused on determining to get that meconium out that they would try too long, and the baby's actually not getting ventilated at all. So the idea was, you know what, the meconium's down there, just ventilate, expand the lungs, deal with the meconium afterwards. It's the safer thing for the baby. It'll be interesting to see, because I think it's going to happen at some point. We may have a bit of a reversal on that, because my question would be, sure, that should be the approach that we teach the general population, but what about a bunch of experienced people who can secure an airway quickly? So we don't have the data though, but at some point somebody may do a trial and say, okay, let's look at the incidence of meconium aspiration syndrome with pulmonary hypertension with a neonatal team versus rural centers and so forth, and see if there's a difference. But right now, the message that we're being given is just establish ventilation.
Because a lot of centers, Michael, they're taught, they get the tube in, like say like you're a midwife up in a health center, and you get the tube in, and you're taught just to put a suction catheter down, keep going, and nobody's paying attention to what's happening to the baby. Like, does he have a heart rate still? Like, maybe all your attempts to clear the trachea of meconium is causing him problems. And like, I was horrified when I heard that, and I'm like, oh my gosh, because we just keep going down till it comes back clear, and it's like, what's the baby doing?
Yeah.
It's like, oh.
I would say that's not good practice.
Yeah.
Good lungs, but dead is not good.
Yeah, you can sort of treat meconium aspiration. You can't treat dead.
Yeah. Now this condition is awful.
Yeah.
I mean, it's a bad condition. Because you get really four main problems with it. One is airway obstruction, and we talked about the ball valve mechanism. So what happens is, imagine you've got this little chunk of meconium sitting in the airway. When you breathe in, you get dilation of your airway, so air gets past this ball of meconium. When you breathe out, your airways collapse a little, so it may go around the plug. So air goes in, can't get out. Air goes in, can't get out. So that leads to areas of hyperinflation, areas of collapse, which from the RTs group will know, and maybe the nurses know too, when you have very heterogeneous disease, it's very difficult to ventilate. Certainly with conventional mechanical ventilation, the ventilation will go down the path of least resistance. So what you'll have is the areas which are receiving air just get bigger and bigger and bigger. The areas that aren't receiving air get smaller and smaller and smaller. So that's where the high frequency jet comes in. So this would be a condition where the jet would be quite useful. Now, as that area, as the alveoli and the certain terminal sacs continue to get bigger and bigger and bigger, they can burst and get a pneumothorax. If you have this inflammatory material sitting in the airways, that leads to a dramatic increase in inflammatory mediators, which can cause reflex pulmonary hypertension. And then the meconium itself can just cause a pneumonitis and make your lungs very stiff. So the jet ventilator really is the optimal treatment here. And what this is meant to show you is, you can see here the lungs are darker in here, and you've got this patchy white here, maybe a little bit of patchy white in here. And so that's the typical X-ray for meconium aspiration. And yeah, these kids can be quite sick. This is sort of end stage. So can you name two things that are wrong with this X-ray? Yeah, there's a pneumo. What's the second thing that's wrong?
There's heart shifted.
The air up the trunk.
Well,
you got air
The heart shifted. Okay. What's this? Where is the heart? Would you agree the heart is sort of this structure here?
Yeah.
Okay. Where's the diaphragm?
Oh,
Yeah.
on the right side.
Can you see the diaphragm?
No.
Why can't you see the diaphragm?
There.
Well, the diaphragm's there.
Oh.
Yeah, well, you can't see it because it's got air everywhere, right? But you got a stomach bubble here. So normally, when you look at an X-ray, I'm going to go back up. Here's the diaphragm. Look at under the heart. See how it's solid white?
Yeah, there's air under the heart in that one,
Look at that. What do we call that?
isn't it?
Pneumopericardium.
Cardium,
Yeah. So that's a lot of air where it shouldn't be. And there's actually a third problem. This line is way, way too high.
yeah.
Yeah. Yeah, this line needs to be pulled back. How common is it? It's common. And this is why we used to get so much practice. 10%, 1 in 10 deliveries we would see some degree of meconium. And meconium aspiration syndrome varies widely. Yeah, it very depends on the center. I think it depends on the practices. So why the big range? I think it has to do, again, how you manage it. So if you aren't able to get on top of it, it can get quite sick quite fast. Whoops. Also change in obstetrical practice. I think this has been a big one. We went from a practice in obstetrics to just saying let the women go when they go, to recognizing that after you hit 41 weeks, that time between 41 and 42, all complications start going up. I know some of you have had kids. I don't know if any of you went past 41, but typically your obstetrician would say to you, if you hit 41, like you're in there at 39 and you're saying, I feel terrible, I want this baby out. At 40, you're saying, I need this baby out. At 41, you're saying, please take the baby out. But if you have got to that point, the obstetrician will say, at your 40-week visit, they'll say, okay, if you're not delivered in the next week, we'll bring you in for an induction. Because they know that they're asking for trouble. Interestingly, you go back to 1976, and this is when it was first described about this suctioning. So what they did was they just looked at historical controls. And it's interesting that no one ever really looked at this. This whole idea, how we go in the mouth, and then we used to, in case room, you'd see they would go down all the way to the stomach, and we've discouraged that.
They still do it.
Yeah, because we've been discouraging it not to go all the way down to the stomach. I think sometimes, this is a little informal, but I think some people like doing it because it's almost like squeezing a pimple. It's like they just are so curious how much stuff they can get out, right? So they go, even though there's no benefit to going down to the stomach, people just do it. And so certainly when I see it, I remind people you don't have to go down to the stomach. And so yeah, this became dogma based on one study. This looked at suctioning. This was intrapartum suctioning, showing that there really wasn't any big benefit for that. And besides, we've abandoned that. We're getting rid of that. Now the baby's delivered, so now what do we do? Right now, for the next few months, we are intubating, right? So, yeah, who? Now, having said that, I mean, we're supposed to intubate because we're not supposed to take over. Like, we're still supposed to teach up until the first.
Yeah,
Like, I just did a course, and I still had to teach that we're intubating because I was told I have to. But what I would say is, sure, maybe try to intubate, but don't, like, if you try once and you can't get it, don't continue to try. Just go in and bag the baby. So how long does it take? How easy is that? So the NRP always recommended under 20 seconds for intubation. But we know from actually an ex-Canadian who's now just retired, but he was in California. He had this wonderful video camera that he would put on a simulation cart, and name's Feiner, Dr. Feiner, and he would look at videotaping resuscitations, and he actually showed even the most experienced intubators could not get that tube in the right place and get the suction of the meconium before 25 seconds. And so he showed that on video. this was thought, these studies certainly looked at tracheal suctioning and thought that there was a benefit. We now know there's probably not. Wiswell, this was the big study. If you were ever wondering why it became really standard to suction out the trachea, it was by Thomas Wiswell in pediatrics, and this was where he broke it down to thin, moderate, and thick. And what he looked at was, is there any benefit, risk of developing Meconium aspiration syndrome? He found actually, based on whether it was thin, moderate, and thick, it really made no difference. And the reason this study was important was because up until this point, we used to ask that question, is it thin, is it moderate, is it thick? And then it changed to just meconium because it was recognized really it doesn't make a difference. And it probably doesn't make a difference because at the end of the day, it's the kids who are flat who are the ones who actually have inhaled it. The ones who are not flat haven't. Factors found to predict risk of Meconium aspiration syndrome. Unfortunately, us boys are always the problem. So males always do worse. Oligohydramnios. I mean, you can look through all of this stuff, but in this one, no oropharyngeal suctioning was found to make a difference, but and thick versus moderately thick. But at the end of the day, the message here is it probably doesn't matter anymore. Whether it's thick, it's not thick, whether you suction, whether you don't suction. The message I want to give you is just establish FRC. Get the lungs open, because if the lungs are not open, you're going to have a problem. So here's the current thoughts. We just talked about establishing FRC. This, I can't overstate this. One of the challenges this team is going to have, and it's not just this team, it's our fellows, it's our neonatologists. I'm sure I'm not the only one that recognizes this, but when no one can intubate somebody and they call me at 4 in the morning and they say we can't intubate, I'm the one who intubates maybe 2 or 3 times a year, right? So I'm not the most experienced intubator. And so that gets diluted more and more and more. One thing that may help is we're looking at a video laryngoscope, which I think will help a lot. So we're certainly looking at having that in the unit. And the reason I think that'll help is because it'll allow, like, let's say you're there and you obviously can't both intubate. Albert can, as he's looking, you can look on the screen next to him and you'll see exactly what he's looking at. And you'll say, okay, that's what he's putting the tube into. I can see, and as he's repositioning, you'll actually see how the view changes with the repositioning of the blades. So it'll allow for shared experience. And so we're certainly in the process of pricing those out. I talked about this study from 2004. Lane is the primary author, but Feiner was the other one. And this is actually how long it takes. So 50 videotaped successful intubations. I put this in for you guys so that you don't stress out, because intubation can be stressful. Because, of course, when you're intubating, and especially when you're learning, you've got the neonatologist standing over here, you've got fellows over here, everybody's waiting in the wings for their chance to intubate if you can't get it, right? But the reality is this is how long it takes. So when you look at the numbers of intubated, in this study of 50, 4 were intubated within 10 seconds. Okay, so when somebody says that, they can intubate like that within 3 seconds, they're either lying or they're one of the minority. Okay. What's that?
It's Al McCurry.
Yeah.
So then, but look, some people, 20% took longer than 40 seconds to get a tube in. Okay, so people are across the board. And again, these were neonatologists, RTs, fellows. But 72% are successful under 30 seconds, and as Meconium I mentioned, I said 25 seconds, 23 seconds. And so the other question is, when people talk about, well, you just explained how they do it with the catheter, but when people would say to me, oh yeah, I intubated 3 times, I would look at them and be like, really? Because I think, well, on the one hand, that may sound impressive. On the other hand, I'm thinking, did you spend a minute and a half intubating? Like, how did you actually do that? One trick that I use, I don't do it anymore because I'm not there intubating for meconium, but if you did have to intubate for meconium and you were going to do intratracheal suctioning for whatever reason, rather than using a catheter, because the catheter is so small, what I would do is I would put the laryngoscope in. Once I see the airway, I call for the tube, suction, and I just never take my eye off, and I just keep it out. Because what people used to do is they would intubate, they would suction, pull the whole thing out, and then they go in again, and they, but really, if you have a partner, You just, once you've got that airway, just keep your eye on it and just ask for the tube and do it that way. But again, probably irrelevant. Now, what about treatment? So what can we do for it? Oxygen. So with all of our talk about oxygen being a drug, and you hear about limiting, BPD and all this is a completely different cohort. These are term infants. These are almost all going to be term infants. Give them as much oxygen as they need. You need to cause pulmonary vasodilation. Milrinone can be very useful because if you've got, do you carry, I can't remember, do you carry Milrinone on transport?
We have it in the P.
Yeah. So, of all the inotropes, Milrinone's probably going to be your best bet because if you've got pulmonary hypertension, Milrinone has 3 very, very good qualities about it. Number 1, it's actually a pulmonary vasodilator, so it'll help with pulmonary hypertension. Number 2, it's got something called lusitropy. Anybody know what lusitropy is?
Isn't that the contraction of the heart?
In what way? You're right.
Greg was just talking about it not
Oh,
long
okay.
ago. I can't remember.
Yeah, so it doesn't so much cause
Or the relaxation.
it's the
Pardon me,
relaxation, that's right.
piece of it.
Lusitropy is relaxation, so it causes the heart to accept more blood. And if you've got more blood in the heart, you get a bigger stroke volume, it's more effective. Okay? And then it also causes systemic relaxation, so it allows the heart to pump forward. Okay? Paralysis and sedation. So for those of you who have worked with me, when a kid is really sick, one of the lines I say is, "No child on my watch will die without being paralyzed." So that's something I always try. If I'm just getting nowhere with everything, I paralyze them because sometimes maybe they're just not allowing the ventilator to do what it needs to do, and they're fighting, and just I take them out of it. I sedate them, I paralyze them, not for a long time, but just to see if when we take control completely, it helps. INO, very important in the treatment of pulmonary hypertension. I have in combination because, in the future you might bring sildenafil along. I have my doubts that we'll do that in the short term. Surfactant. So certainly, if you've got Meconium aspiration syndrome, getting some surfactant down the tube will replace that which is deactivated, because surfactant, with its inflammatory properties, actually deactivates surfactant. So it's important to have that available. Steroids are very controversial. There are some centers, we don't do it here, but there are some centers that within 4 hours of birth, there's animal research to show that you can ameliorate the severity of Meconium aspiration syndrome if you give steroids to animals. But again, we don't typically do that. But you might read about it somewhere. So yeah, so the basic principles of treatment are get the lung open. That's the most important thing. Get the lung open and recruit. And the other thing would be, again, if you have areas of collapse and areas that are open, to anticipate. So a good question would be, if you're getting called for a baby you think has Meconium aspiration syndrome, better to plan to take the jet if possible. Okay? Not the airplane, but the high frequency jet. Always think about surfactant in these cases. Even if the baby's not on a lot of oxygen, surfactant might help. Steroids, again, I used to give steroids periodically for some of the severe cases. I don't know if it really worked or not, but I did give it. And pulmonary hypertension, INO has made a world of difference. When INO, interestingly, though, there was one human study on steroids, and it was never completed. And the reason it was never completed was because INO came along for availability, and nobody was using the steroids anymore because the INO made such a difference. So yeah, inhaled nitric oxide, very, very effective. Surfactant replacement, certainly, here's the data to show it. Surfactant replacement, basically average 36% reduction in need for ECMO if you give surfactant. There's even been some studies on surfactant lavage, so taking multiple doses of surfactant, basically washing out the surfactant. You just flood the lung with surfactant, and you keep suctioning up meconium, because it floats the meconium to the top.
What's your dose on surfactant?
It's 5 milliliters per kilogram, up less.
Is there a max?
Is there a max? Well, we typically give a dose. I mean, for transport, you'd give a dose. By the time a second dose was needed, you'd be back at home base.
Okay.
We only carry 3 vials, just so you know, so
Oh,
now for
okay.
3
So it's only 50.
kilos, so if you have a 4 kilo, you just give
That-
what
give what you can?
have, and,
Okay.
and that's all we have.
You can all on transport.
And also
Couldn't take
we,
a full vial.
I can't think of ever bringing a jet from
Super.
that, I mean, we always bring INO.
We've taken the jet to Edmonton.
We've taken,
Yeah, I know
like,
the jet's
when we
went
set it
down,
up
yeah.
here,
Stances, yeah.
yeah,
Yeah.
but we've never taken it.
Yeah, I mean, we wouldn't do that lightly. It would be for a very, very, very sick kid.
Because it takes a long time to set it up for transport, so it would probably be better if we could get there with INO and
Yeah.
whatever. It takes a couple hours to set up, I think, a jet.
So you're saying practically speaking, it would be like.
Yeah.
Right.
So I'm going to go through this a little quickly, but the approach, I love the mnemonic dope. Did Greg already cover this? Okay, so we'll skip over dope. We've already got it. If you've got a pneumothorax or you think there's a pneumothorax, make sure you transilluminate. That's the fastest way that you're going to determine whether or not there's a pneumothorax. When in doubt, I always put a needle in. So if the baby's deteriorating, sudden deterioration, FiO2 is very high, and their gas, let's say, was bad by the time you get there, if you transilluminate the chest and it's asymmetric, so one side looks quite bright and the other one doesn't, you can wait for an x-ray to confirm, but if the child's really deteriorating, I would just put in the needle, drain it, and determine if there's air in there, because that can be life-saving. And now, if there is a persistent air leak, so the strategy that I think for the transport team that you want to do is you want to try needle decompression first. And if you slip a needle in, you suction out 20 mils of air, then you take the needle out. If the baby's fine after that, you do the x-ray. If the x-ray shows there's no reaccumulation of air, because remember at 60 breaths a minute, it's going to reaccumulate pretty fast if it's still there. You may avoid some chest tubes, okay? What I want to assure everybody is, I've had the opportunity recently to put in several chest tubes with the Thal Quick chest tube set. It's very easy. Now, have you done the simulation on that? Yeah, so it's actually a very, very easy thing to do. So landmarking is the most important thing, but you know, compared to the way we used to do chest tubes with having to tease open the pleura and whatnot, it was the muscles and going over the ribs and whatnot, this is much, much easier. I won't describe how to do it, but there's also videos to show you how to do it if you want to see that. Like right here. Forgot that I had this video. You've got the link here, so I'm not. I think originally I was. Actually, let me just see if I can find the video. I don't think it's that long.
I don't think YouTube works in Internet
Oh.
Explorer.
Well, it doesn't work in,
Oh,
You have to do it in the
Yeah.
all right.
Tom,
Oh,
just sit on.
hold on. You know what? Use it at your.
Firefox.
It's okay. Please look at the video. It's a very nice video. It just shows you very quickly how to do it. It's very little to it, and that's the end of the slideshow. If you know, I think when I think about procedures, I guess by a show of hands, how many people in here, don't be shy, the idea of putting in a chest tube makes you a little nauseated? Okay, right, and that's what I assumed, right? And I knew that because, you know, I'll tell you the truth. The truth is, even for most fellows, I think, when they haven't done one for the first time, especially the old way that we did them, which was quite barbaric, you know, it was quite nauseating to put it in. When you pop through and you think, oh my God, did I just lance the lung or the heart? You know, it could be very scary. Now with the new one, I want to assure you, it's very easy, and it's slick. So the idea with the new one, and I'll just describe you how you do it. If you put in an IV, you can put in a chest tube. Okay. So how does that sound for putting your mind at ease? So what you do is you find, you know, your fourth intercostal space. Okay. You go anterior, and then what you do is it comes with like an introducer needle.
The nurses are going to the fellows boot camp,
Okay.
so they'll be attending the chest tube insertion.
Okay.
Right after.
But I'll just put your mind at ease by letting you know.
What else?
Scheduling. You guys have been scheduled for clinical.
Yeah.
Sorry.
Not available that day.
But we'll get you. I think it's important to
You'll be
have.
doing a workshop.
It'll be very important to have everybody in tune with this because if, let's say, the nurse's hands are tied, middle of putting in a line, you need somebody who has a free hand to do it.
What day is it? Sorry?
July
You
5th
are-
and 6th.
You're the
We'll talk
one
about it
free.
in a minute.
Okay.
You're free.
So you take your introducer needle, you put it in, then what you do is, once you get that pop of air back, okay, what you do is you take the end off and you advance, there's a wire, okay? The wire goes through, then you take the needle off the wire and you've got a wire sitting in a chest, okay? Then what you do is, there's no cutting. We used to do this nicking and whatnot, you don't have to do that. Now you take, there's a little dilator, there's a slim one, and what you do is you take the end of the wire, you slide this dilator over, okay, and you just push it into the chest wall, it just opens that hole a little bit. You take that off, and you take the bigger dilator, you slide the bigger dilator on, and by this point, by the way, you can relax, because once you poke the hole in the chest, the air is going, okay, so now you can relax, okay, so you've drained the pneumo. Then what you do is you put the bigger dilator in, turn it a little bit, make that hole, slide that out. Then what you do is you take your chest tube, and for a third time you make a pass. You put the chest tube in, you watch that little side hole go in. Once it's gone in, and you no longer see the side hole, you've advanced it maybe another centimeter. What you do is, there's a hub at the end, and that has the central, basically it's like a guide wire, it's like the guide for the wire. And basically what you do is, you start, as you're pushing the chest tube in, okay, the wire's out the end, and you just start pulling on the wire. Okay, so the wire that you've slid the chest tube over is here. Once the chest tube's in, you just start pulling this little hub at the end, and the hub comes out. So the hub and the wire both come out as one, and your chest tube's in. Okay, so it's actually, I mean, it's more advanced than an IV, but really, if you can put an IV in, you can put a chest tube in. Because you put the wire, so again, you just put the hub in, take the needle out, put in the wire, dilator, chest tube, pull the wire out. And then once you're in there, for transport, you don't have to worry, like some people suture them in. Recently, the ones I've done, I've just taken like a Tegaderm or some other dressing, occlusive dressing, and I just put it down on the chest, cover it, and then you put it to an underwater seal. Yeah, so it's actually, that's what the video shows you. It's very straightforward, much easier than it used to be. And what I would say is everyone has to be confident in how to do that. Statistically, the number of chest tubes you're going to place on transport is extremely low.